Good afternoon to all of you. I'm Dr. Jyoti Menon, Director of Infertility Services, and with me I have Dr. Ashwini Mahesh, who is one of our senior consultants. We both are attached to the Gunushila group of hospitals, which has centers in Bangalore, Mysore, and Pune. I am sure a lot of you who are listening in have some issues with conception, and we at Gunashila have decided to start a series of patient education programs which we feel may help you to understand your particular problems better. Today's talk is specifically this thing with intrauterine insemination or IUI, which is a fairly common fertility treatment which has been recommended. And then we will also be covering a little bit about the test tube baby or the IVF ICSI procedure. You are free to text in your questions related to these two subjects, and we will be taking your answering your questions at the end of the program. Dr. Ashwini will start telling you all a bit about these two particular topics.
Good afternoon. Before going into relevant investigations, what is required in IUI or IVF, we will in brief discuss what is IUI, in whom IUI is really indicated, what is IVF, and in whom IVF is really required. What is IUI? Insertion of a prepared semen into the uterine cavity during the time of ovulation is called IUI. The husband's semen is processed in the laboratory to obtain healthier sperms, which is then deposited into the uterus around the time of ovulation. Whom IUI is really required. Since IUI is a very popular procedure in couple who are undergoing infertility, basically because of two reasons. One, it's a simple procedure. Second thing, due to its cost effectiveness. But not all couple who have infertility really require IUI. So we have just briefed who all really require IUI.
I would just like to add here that Dr. Ashwini has already explained to you regarding you can use the husband semen, but she will also tell you conditions where sometimes we may have to use a donor semen also, and the procedure is still called an intrauterine insemination.
In women with initial stages of endometriosis, that is grade 1 or grade 2 endometriosis, where other modalities of treatment have simple treatments like they're tried naturally, or ovulation induction with timed intercourse hasn't helped. In women with cervical factor basically means there is alteration in the cervical mucus production. As a result, the cervix becomes hostile and it doesn't let the sperms ascend into the uterus. And in women with mild subtle ovulation abnormalities, where they have tried expectant treatment or they have tried ovulation induction and it has not worked in them. And in couple who have unexplained infertility, basically all their parameters, baseline investigation is normal, but still they are not conceiving with either naturally or with ovulation induction. Then
I would like to just add here that in unexplained infertility, you may wonder, when everything is so natural, why should we try? But there have been studies which have shown that conception rates are much better when we do an intrauterine insemination along with ovulation induction, rather than only a simple ovulation induction with time intercourse. The pregnancy rates are much better.
Coming on to men, in men who have anatomical defects, basically there is problem in the outflow tract of the semen, such as hypospadiasis or retrograde ejaculation, where the ejaculate instead of coming out goes back into the bladder. And in men with psychosexual dysfunctions, basically these are couple who have erection problem, ejaculation problem, or they have decreased libido. And even in women who have psychosexual dysfunctions such as vaginismus, where they cannot get into the natural process of intercourse. And impaired seminal parameters include men where the semen parameters are mildly abnormal in them. And there are other indications for IUI also, like Dr. Jyoti ma'am was telling, when we prefer donor semen in certain group of couple where their husband has no sperms in his semen, there due to the cost due to the costly IVF procedure, they may opt to go for donor insemination, or when there is a role like they have some genetic disorders which are running in the family, and it is basically a sex-linked disorder, then changing a gamete would help there. And men who are on anti-neoplastic, anti-cancer drugs, or men who have chronic medical conditions such as diabetic neuropathy, or they have had a spinal cord injuries, in all those also IUI definitely helps. Even in women, like a single woman, an unmarried woman who wants to become a mother, IUI has a role in that.
I want to emphasize, she's already mentioned that in impaired seminal parameters, we will tell you a little later what are the cutoff rates before which you can think of an IUI and when you really should not be recommending an IUI, because below that the pregnancy rates are really, really very low.
Next, coming on to what is a workup prior to IUI. There are few investigations which are must in a couple prior to going for IUI. Basically, in a woman who is who wants to undergo an intrauterine insemination, we have to confirm that she is ovulating. That is, she is releasing an egg. Which can be confirmed either basically from history, whether they have regular cycles, or prior cycles where they have had ovulation induction, they are ovulating, or with urinary LH kits. There are various ways to confirm ovulation, so we should make sure that she is ovulating. And the second most important test is tubal patency. The fallopian tubes, either one of the fallopian tube must be patent. For a man, a detailed seminal analysis is must. In some women who have not responded to one cycle or two cycles of IUI, we have to also rule out whether there are any other endocrinological abnormalities like thyroid disorders or hyperprolactinoma, and we also might require some reproductive hormone assays such as FSH level, LH levels. But basically, the most important are ovulation, tubal patency, and semen analysis.
And like Dr. Ashwini said, ovulation, we assume that if they have natural cycles, they're probably ovulating, but you may have to do some kind of monitoring in order to reconfirm that. And if they have irregular cycles, they most probably require ovulation
induction. Then for a women, before starting an IUI, we would prefer to do a ultrasound. Basically, in infertile women, we prefer to do a vaginal ultrasound. The advantage of vaginal ultrasound over abdominal ultrasound is it gives a better clarity of picture and the accuracy is much better. When we do an ultrasound, what all we look into, there are no abnormalities in the cervix, uterus, fallopian tubes, and the ovaries. And also we see what is her number of eggs she has. Is there any cyst in the ovaries which is going to obstruct our treatment? And usually fallopian tubes are not visible on ultrasound. Only they are seen if there is any damage to the fallopian tubes. Then another test I told you which is a must is a tubal patency test. That is HSD is a simple procedure which is performed in most of the centers, but depends on the centers. Few centers do it with sedation, few centers do not give any sedation, but we prefer doing it with sedation because it's a painful procedure. During HSD we insert a small catheter into the uterus and we inject on dye. The dye fills in the uterus and then comes out through the fallopian tubes, during which we take an X-ray to make out whether the tubes are open or blocked. So the image towards your right shows is an X-ray picture which shows the uterus, then the fallopian tubes, and the spillage of the dye.
Okay, I want to add a couple of things here. One is, in our center, we believe in testing tubes, and this is our primary and the first method of testing. Like Dr. Ashwini said, this is done under GA in our hospital, and along with that, because we give the HSG, this is a permanent record of what we can see inside your uterine cavity and in your tubes.
Then for husband, he should have a detailed semen analysis wherein we have to see what is the volume, what is the concentration of the count, what is the motility, and what is the normal forms, is there any presence or absence of any infection in it. All this have to be looked in detail because there are certain cutoffs beyond which IUI might not help. As I've already told you about this slide, What are the cutoffs? WHO 5th edition has given a cutoff of normal range for a volume of about 1.5 ml. Count should be at least 15 million per ml. The motility, progressive motility should be 28%, and the overall mortality should be 32%. Vitality should be 59%, and the normal form should be at least 3%. So any variation, that is either low counts or decreased motility or decreased normal forms, in such couples, the chances of pregnancy with IUI will be low.
Just want to
add, ma'am?
no, I just want to say again, tell whoever has joined in between, please text in your questions related to the talk we are doing, and we will definitely keep some play time for answers at the end of this presentation.
What is the success of with IUI in best of the centers? I want to stress about it. There are centers who tell they have high IUI 100% success rate, but frankly speaking, in best of the best centers, the success rate with the IUI is 18 to 20%. Even in our center, it is about 18 to 20%. Once they be in these 18 to 20% couple who become pregnant, there are chances of abortion in about 3 to 5%. So finally, baby take home rate is around 15 to 17%. How many cycles can one try with IUI? This is a very controversial topic, and there have been several studies, but what we have seen and what other studies suggest is the pregnancy rates are maximum with first 2 cycles of IUI. Then from the third and the fourth cycle of IUI, the pregnancy rate shows a downward trend, and after fourth IUI, there is the success with IUI is very less. So what we would recommend is a couple can try maximum of 3 cycles of IUI, and when it's not happening, it would be better to opt for IVF. Next, coming on to what is IVF. Fertilization of the egg and the sperm in the laboratory under controlled conditions is called as IVF. You all know about it, and it's become a very common topic now, so I'll go further. In whom is IVF really? Absolute is, these are the real indications. That is, in women who have bilateral tubal damage or bilateral tubes are blocked. In men with severe male factor fertility, where the count is less than 5 million per ml, or there is no sperms in the semen, that's called azoospermia. In grade 3, grade 4 stages of endometriosis, women who have diminished ovarian reserve, that is their egg producing capacity is very low. Then in certain familial genetic disorders, in certain couple who have some specific genetic mutations, in them we can do IVF, screen those embryos for presence of those genetic mutations, and transfer of embryos which do not have genetic mutations will prevent the genetic disorder in that baby, as well as transfer it to further generation also. And the last one is fertility preservation. Fertility preservation for cancer patient. Because of the recent advances in chemotherapy, cancer treatment is giving us good success rate. So these couple would want to conceive later. So in such couples, preserving their gametes even before starting cancer drugs will give good results.
Okay, just go back, Ashwini.
Yeah.
Okay, I just want to add a couple of things here to what she said. When we talk about bilateral fallopian tube damage or blockage, this also will include the group of patients who had tubal sterilization and who do not want to undergo the tubal anastomosis, recanalization. And in fertility preservation, we have what is called social fertility preservation also. Tell them what
social freezing, wherein women who are postponing their childbearing, either due to their commitments, due to their social commitments, or due to their health conditions, they have to postpone their childbearing. Those women can freeze their eggs at a younger age, and later, when they have the plans of pregnancy, can come use their eggs and then get pregnant with it. Then relative indications, as I've told, when they have tried IUI or they have tried multiple treatment cycles and it's not worked out, in such couples, relative indications like unexplained infertility, elderly women more than 36 years, repeated IUIs they have told, as I've told you, 3 or 4 cycles of IUI, it's not working for them. Then grade 1 or grade 2 endometriosis, who have already tried initial type of treatment and pregnancy is not happening to them. And even PCOS women who have already tried ovulation induction with the timed intercourse, or they have tried ovulation induction with IUI and they are not getting pregnant, in them IVF would be a better option. What is a workup before first IVF? we would have already worked up the couple for IUI. Apart from what workup we have done for IUI, very few investigations are required before starting the first IVF. One is an AMH. It's an anti-Mullerian hormone. It's going to give us an idea where the woman's fertility status stands. So it will tell us how many eggs she's going to produce, what kind of stimulation is good for her, if she's going to hyper respond, or how her response is going to be. To plan for us for planning, it is going to help. Then uterine cavity evaluation and mock embryo transfer.
Okay, I just want to add, when she said planning, yes, and counseling.
Yeah, and
Counseling. Counseling is very important because you can tell them, depending on your ovarian reserve, what is the stimulation. Stimulations choosing is more for the doctors. For patient, it is what can they expect out of the stimulation. As far as their response is concerned, the AMH will help us.
Uterine cavity evaluation is a must. Basically, we are going to form the embryos, we're going to pick the eggs, we're going to form the embryos in the laboratory. Ultimately, when we transfer it into the uterus, we do not have a much control about it. So we have to make sure that the inner aspect of the uterus, the internal environment of the uterus is good. So we can, for first timers, they require is just a 3D scan. If the 3D scan is normal, we can proceed with IVF. And mock embryo transfer is like a dummy embryo transfer. We're going to use a catheter which is similar to embryo transfer catheter. We're going to pass it into the through the vagina and the cervix into the uterus, and we are going to note down the directions so that we don't have any difficulty during the original embryo transfer. And for male, we would require DFI. DFI is nothing but DNA fragmentation index. It gives us an idea whether there is any DNA damage to the sperm which is there in the patient. And if it is there, then we could treat it with medications and certain lifestyle modifications. By doing so, we could improve the success of IVF, and also we will reduce the chances of miscarriage.
Even if it is the first IVF, Ashwini, in which case would you recommend doing DFI?
Especially if the husband is a smoker, he has diabetes, then
severe male
factor,
of course, which is one of the indications, and repeated
IUI
IUI
failures.
So these cases we definitely require.
Then what happens if the first IVF fails? What are the tests we have to do again for them? So when we consider the pregnancy as a whole, majority of contribution, that is 70% contribution, comes from the embryo, and the 30% contribution is from the uterus. So 70% of contribution, how could we know whether the embryo we are putting in is normal or not? So we do something called as pre-implantation genetic screening. We grow the embryos up to the 5th day, and we take out few cells and we send it to a genetic lab to test whether the chromosomal content in it is normal or not. And transferring such chromosomally normal embryos will increase the pregnancy rate by another 5 to 10%. But before doing PGS, we have to get a genetic screening of the couple, the husband and the wife, to make sure they do not have any genetic chromosomal abnormalities, which we have to specifically look in the embryos. Then coming to the uterus, what all we do, we have done already a 3D scan. Despite of she's not pregnant, then we do something called as hysteroscopy. In hysteroscopy, we pass a thin telescope into the uterus and we have a look into the inner aspect of the uterus. Is there any abnormal features which needs to be corrected prior to second IVF? And also, India has a high TB burden. We are all prone to tuberculosis. So it's an endemic in India. So we have to make sure that there is no endometrial tuberculosis. So we can do endometrial tuberculosis testing in them. And certain hematological conditions such as autoimmune disorders such as antiphospholipid antibodies, systemic lupus erythematosus, then thrombophilias and hyperhomocystinemia, all these can also have an effect can have an effect and decrease the pregnancy rate. So we have to screen the woman for such conditions and take specific precautions prior to her second or third IVF to improve the success rates. Then last thing I want to tell us about endometrial receptivity array. It's going to tell us whether we are putting the embryos in the proper time. There's something called as window of implantation. That is, it is a time duration during which the uterus will accept the embryo. So we have to do a test and we have to confirm whether we are transferring it in the right time.
In the previous cycle, whether we've transferred it in the right time.
Right time.
Okay, and to whatever she has said, I just want to add a couple of things that please remember that this is not recommended for everybody, either of these tests. Very specific group, especially if you have had failures in initially and you are very disappointed, along with you all, we also want to know how to improve your pregnancy rates. We understand that all these will individually cost you more, but at the end you want to take home a baby. That is why we also want to do all these tests. We recommend that you do all these tests for us to understand the uterine cavity better, and also help us choose better embryos which we will transfer into you. Now, I think we have come to the end of our presentation, and I can see one question. Okay, before I take that question from Mr. Rohan Nayak, I would like to ask Ashwini a couple of things, like specifically about IUI. Like, are there any factors which will really influence how a patient becomes pregnant with IUI? Or is it like IUI done in anywhere should give you the same results?
When we are when we want to undergo IVF, what are the main
IUI.
factors? IUI. What are the main factors you have to look into? You have to look in whether the center which you're going has an andrology lab within the center, because once the semen is processed, there is a particular time duration within which the semen has to be inseminated. That is, it has to be inserted into the uterine cavity. So if it goes,
minutes.
yeah,
There's
90
a 90
there is
minutes
a 90
cutoff.
minutes cutoff.
It will give you best rates if the time from processing insemination, collection insemination, this thing is 90 minutes.
And also,
anything longer than that will reduce pregnancy rates.
And one more thing I want to tell you is it is to be done along with follicular monitoring. When there is no follicular monitoring in the IUI cycles, then we do not know exactly what was the follicle size, whether she has ovulated or she's not ovulated. So follicular monitoring is also a very important thing which has to be taken care.
And I also want to add that technique is also equally important. Tell them how do we do the IUI in our center?
We follow something called as no-touch technique, wherein we during around the time of ovulation, we once the semen is prepared, when the semen is processed, within 90 minutes we go ahead and do the intrauterine insemination. We have a set of protocol, and it's very specific in our center, wherein we do a thorough vaginal cleaning with the RO water. Then we insert a cusco speculum to expose the cervix. We remove the cervical mucus plug which is there, and then we use preferably soft catheters, and we draw in the sample, and we just go into the uterine. We cross beyond the internal os and we insert it. We make sure that we are not going to touch any walls of the uterus, and we are not going to cause any injury there.
In fact, because we are basically an IVF center also, the IUI technique is almost replicated what we would do in an embryo transfer.
In
IVF embryo transfer. Okay.
What kind of food would you suggest to improve fertility? Is
non-veg
good or bad for fertility?
There's no proven this thing. No. Tell them. Basically, they tell you to have a lot of food which has good antioxidants.
Antioxidant-rich foods. Basically, it includes all the colored vegetables what we get: carrot, beetroot, then 3 colors of capsicum, then a lot of sprouts, that is high protein. They are cucumber, broccoli. All these are rich in antioxidants. They have to consume a lot of liquid.
I don't think great studies have been done as specifically regarding fertility, vegetarian and non-vegetarian. But if you look at the general advice now going around in the world, that everybody turns into vegetarian, and in fact veganism. To give up meat completely. Okay, what is the other question he has? Epilepsy.
Epileptic patient can conceive through IVF. There is no contraindications for it, but definitely we have to make sure that we have to change her medications. If it's a woman who is having epilepsy, then she requires change of medications, because there are most of the older anti-epileptics which were there have an effect on the embryo. It can affect development of the brain and the spinal cord. So we have to change over to a safer medication, and then they can conceive.
Epileptic drugs themselves may not have this thing. Only she has to be completely medically checked to make sure that there is no problem, because we do what is called an egg pickup, which is under anesthesia.
And they have to get a fitness from their neurologist that we can proceed with.
We have done lots of
we have done lots of patients with epilepsy.
Thank you. That is the end of our session. I don't think there are any other questions. We will see you again next Tuesday at 1 o'clock.
Thank you.
Thank you.